Welcome to the ERN-RITA webinars. My name is Ingeborg Bajema and I'm the moderator of this session. Today's webinar is called Evaluation and Early Diagnosis of ANCA-associated vasculitis. It's my pleasure to introduce today's speaker, Dr. Irmgard Neumann from Vienna. Dr. Neumann is a nephrologist and she's an expert in ANCA-associated vasculitis. She has been working as an associated professor of medicine at the Medical University of Vienna and later at an affiliated hospital at the Department of Nephrology for many years. She currently works in an outpatient setting in Vienna, taking care of patients with autoimmune diseases, especially ANCA-associated vasculitis, in collaboration with several hospitals. She also is a consultant nephrologist at the Immunologiezentrum Zurich and has organized several workshops on vasculitis. Dr. Neumann is an active EUVAS member. The presentation she will give you today was created by her especially for this webinar, with the aim to give an overview of vasculitis, focusing in particular on practical questions such as when to suspect and how to approach patients with this disease in a clinical setting. After the presentation, there will be time for questions. If you have a question during the talk, you can text it. You can find the chat option in the window of the GoToWebinar. So please, Dr. Neumann, I will now give the floor to you.
So thank you, Ingeborg. Thank you very much for this very, very kind introduction. I hope everybody can see the screen and my presentation now.
Yes, we can see it.
Yes, that's great. Okay, so I switched that down. Okay, so I would like to start and welcome everybody who is interested in ANCA vasculitis and early evaluation. And I would really appreciate if you also ready to ask many questions of your interest. In the next 30 minutes, I would like to give you an idea of what ANCA-associated vasculitis is. I would focus on definition, ANCAs, phenotypes first, and then I would like to talk a little bit about the clinical features, patient evaluation and diagnosis. And last but not least, and even importantly, I will try to give you some practical advices in how to suspect vasculitis and how to approach in the clinical setting. Now, there are some key points I would like to share with you, and it's very important to know that it's a rare disease that's a potentially life-threatening disease. And it can occur at any age. It's a systemic disease that can involve any organ. That's very important. And early diagnosis is essential for a good outcome in these patients. And it's a potentially life-threatening disease, and so untreated mortality was over 90%. But with newer therapies, we have now survival rates of more than 90%. So there's a real success within the last recent decades. So this disease has become from a rather fatal disease to a more chronic relapsing disease. But on the other hand, today, the relapses are the real challenge of the everyday clinical practice. Now, what is ANCA-associated vasculitis? And in contrast to medium and large cell vasculitis, it's a small vessel vasculitis, predominantly involving small vessels, but it may also involve medium-sized vessels. Vessels involved are mainly arteries, capillaries, and venals. And importantly, in case of the kidney, the capillaries are represented by the glomerulus. So all variants of small vessel vasculitis can also cause glomerulonephritis. So there are lots of small vessel vasculitis, and ANCA-associated vasculitis is in contrast to immune complex and anti-GBM disease, associated with no or only few lesions that show immunodeposits. So active lesions in immunohistology or the immunochemistry only have few or very tiny deposits. Now, what's the key lesion? And you may see three different types of lesions. In ANCA vasculitis, the key lesion is a necrotizing vasculitis with fibrin necrosis, extravascular inflammation, now leading to more tissue destruction, fibrosis, and damage. And this lesion may be seen by any form of ANCA vasculitis. But you can also see granulomatous inflammation, and in case of the kidney, and I will come to this later, you will find the necrotizing glomerulonephritis. Well, ANCA-associated vasculitis, as indicated, is associated with ANCA, and ANCA is autoantibodies directed to cytoplasmic antigens, namely myeloperoxidase and proteinose, so known as MPO or PR3 ANCA. They play a central role in the pathogenesis and are detected by ELISA, while ELISA have became the standard method in the last years. You also can detect ANCA by indirect immunofluorescence as a C-ANCA pattern for the antigen of PR3 and a P-ANCA pattern for MPO. Importantly, this disease is highly associated with ANCA, so about 95% of the patients with systemic disease will be positive for ANCA. So ANCAs are really, really important and crucial for diagnosing the disease. But importantly, there will be a number of patients, about 5%, that will share the same symptoms as ANCA vasculitis patients, but they are ANCA negative, but they were also considered to be ANCA vasculitis patients. So the ANCA vasculitis is defined as a necrotizing vasculitis with few or no immunodeposits affecting small vessels and associated with MPO or PR3 ANCA. There are two main phenotypes of ANCA vasculitis: the granulomatosis with polyangiitis, the former Wegener's. This disease is characterized by necrotizing granulomatous inflammation and necrotizing vasculitis, and typically involves upper and lower airways and also the kidney. And it's predominantly associated with PR3 ANCA. And the other phenotype is called the microscopic polyangiitis, and it's more the necrotizing vasculitic form of the disease, typically not associated with granulomas and also infecting systemic disease, systemic organ involvement like glomerulonephritis and pulmonary capillaries. And this type is frequently associated with MPO positivity. And the third entity, the eosinophilic granulomatosis with polyangiitis or Church-Strauss syndrome, is considered as a known entity, but there's a subset of patients that will have MPO ANCA and maybe not so dominated by features of asthma. And this subtype may resemble a little bit more the microscopic polyangiitis. But in the recent years, I have to say, it turned out that the differences in the genetic background and the clinical features and also outcomes and treatment response is more clearly defined by the types of PR3 and MPO vasculitis. So it came up to diagnose vasculitis rather as PR3 and MPO vasculitis. And I'll show you some differences here in this table, but I would like to focus on the outcomes. And as you can see here, you will have more chronic and more severe renal involvement in MPO vasculitis compared with PR3 vasculitis. But in contrast, relapse risk will be much higher in PR3 positive disease, but you may also have a better survival. So what are the clinical symptoms? There's a wide spectrum of organ involvement, and this implies that a high degree of multidisciplinary workup is required in these patients. Most commonly, upper respiratory tract and pulmonary disease will be involved, but also the kidneys, and this will be accompanied by systemic and constitutional system features like myalgia, fatigue, or weight loss. But many other organs may be involved also, and I'll show you just some examples to get an impression now. So this is these are lung nodules and masses as a consequence of necrotizing glomerulous inflammation, as you can see here in PR3 positive disease. Here you see an example of pulmonary infiltrates as a result of capillaritis, and this can occur in all forms of ANCA vasculitis, as well as in PR3, but also in MPO positive patients. The imaging technique is mainly a CT scan, where you can find pulmonary hemorrhage and ground glass changes. But you may see on the right hand the picture of a bronchoscopy, where you can find a typical bleeding. Importantly, about a quarter of these patients will develop diffuse alveolar hemorrhage, and this may be a really highly ICU-like situation. It can occur very unpredictably and very severe, and is associated with a very high mortality. And importantly, in these cases, renal involvement is very high in about 90% of the patients. You should also check in these cases the anti-GBM antibodies, because a subset of patients will be double positive for anti-GBM disease and ANCA, and also the diagnosis of anti-GBM disease alone may resemble this situation. Importantly, you may also have interstitial lung disease and pulmonary fibrosis. This is a situation associated with MPO vasculitis and may often occur even before you have systemic disease, and it's associated with worse survival. And I would also like to mention that you may have thromboembolic complications in about 10% of the patients within the first year, and it's highly associated with disease activity and more unrelated to common risk factors. And in a recent paper, some other risk factors for these situations have been described, like pulmonary hemorrhage and PR3 ANCA, but also heart involvement and presence of red blood cell casts. Subclottic stenosis is a serious and potentially fatal complication, predominantly involving PR3 positive patients. It's often asymptomatic initially and becomes apparent as hoarseness, pain, and wheezing stridor later in the course. So together, pulmonary disease is seen very frequently in these patients, and in a recent paper, pulmonary abnormalities have been described in CT findings of 80% of ANCA vasculitis patients. And there are so many various features in findings you may have, and they may represent acute and chronic and severe damage, sometimes at the same time even. And some of them have been attributed to more be likely in MPO positive disease, such as peripheral reticulation, honeycombing, and usually interstitial pneumonia. But some of them are typically found in PR3 positive disease as nodular changes. Pulmonary disease is a really important factor for morbidity and mortality in our patients. The hallmark of PR3 positive disease is also ENT features. Patients present with nasal pain, stuffness, rhinitis for a very long time, and otitis may lead to hearing loss. Typically, brown or bloody crusts and ulcers are found, and patients complain about that for a very long time. These ulcers may lead to septal erosions and septal perforation, ending up in the clinical picture of the saddle nose. Here you can see in the middle. But there are also very aggressive forms, especially if untreated. And I've seen personally this case on your right hand, where a glomerulous inflammation just invaded the CNS system. Skin purpura is the most common feature with respect to skin. You may find in histology the leukocytoclastic vasculitis with fibrosis necrosis. Importantly, no immune deposits are found in histology, and you should always biopsy very early lesions to exclude also other causes and etiologies of leukocytoclastic vasculitis. Importantly, you should also ask for other symptoms if a patient presents just with a single feature of purpura. I would like to come to a case now, and I would like to introduce a 66-year-old man. He's a smoker. He has a history of ischemic heart disease, and he was on aspirin for this reason. He developed arthralgia, hemorrhagic rhinitis, nasal crusting for more than 3 months. And since it was a cold season and he developed also flu-like symptoms, the general practitioner diagnosed the viral bronchitis, and he was treated with an increase of diuretics and paracetamol. But he didn't really improve, and an X-ray later showed a small pulmonary infiltrate. So not surprisingly, he was diagnosed with pneumonia and was treated with antibiotics. But since he didn't really respond, he was seen by the pulmonologist 2 months later, and the pulmonologist performed a CT scan that revealed the ground grass pattern and 2 lung nodules. So the pulmonologist wanted to exclude other malignancy and planned a bronchoscopy. But importantly, at that time, the serum creatinine was 1.8 and no urinalysis had been done. It didn't come to the bronchoscopy because the patient's condition worsened very rapidly, and he was admitted to the hospital with fever, hemoptysis, weight loss, about 8 kilograms, sinusitis, and purpura. And at the time, the serum creatinine was 4.5. And you may have found the typical inflammation parameters like CRP, elevated white blood count, and importantly, somewhat thrombocytosis. Urinalysis revealed hematuria and proteinuria. And the key finding, of course, was the ANCA titer, a very high titer of a PR3 ANCA. So we have now 5 months after the first symptoms, and unfortunately, that's a quite often seen history and journey of a patient with ANCA vasculitis. Now, renal involvement is seen very often in this patient, and it's considered to be a rapidly progressive glomerulonephritis. And I would like to illustrate you here in these pictures that initially, at the very early beginning, you might find clinical dysmorphic hematuria. And this is just a sign of a segmental necrosis very, very early in the course of the disease. But this may develop very rapidly within weeks to a more extensive lesion, like you can see here in the middle of the picture, in form of intracapillary necrosis, extracapillary proliferation, segmental necrosis, and last but not least, the crescent formation, of course. And furthermore, then it will be involved in a more periglomerular infiltration that may lead to sclerosed glomeruli and scars, and clinically, of course, to chronic kidney disease and end-stage kidney disease. So early diagnosis in this patient is very, very, very important. In addition to proteinuria, to microscopic hematuria, you may also find mostly mild proteinuria, and this may represent also chronic damage in these patients. So this is the full picture of the so-called post-immune necrotizing crescentic glomerulonephritis, which is the type of glomerulonephritis you will have in these patients. Well, about 20% of these patients will develop end-stage renal disease by 5 years in all the studies, and this hasn't changed so much, but a little, because in the earlier studies you have had a chance of a 50% risk for death or kidney failure at 5 years when you had a GFR below 50 milliliters. But in a recent study, the PEXIVA study, we see that there's ongoing progress in prognosis of renal disease, and the percentage was only 30% in this study. But noteworthy, the higher the GFR, the better the prognosis in every way. But besides this GFR, other renal prognostic parameters have been described, such as the histology, and in the burden classification, glomerular lesions were linked to outcome parameters, and renal outcome was much better when in the predominance of focal and crescent lesions as compared to mixed or sclerotic lesions in the study. But in addition to the burden classification, the Mayo chronicity score also included tubular interstitial changes such as tubular atrophy and interstitial fibrosis, as well as arteriosclerosis. And these changes were linked to a prediction of the eGFR at 18 months. And in a recent suggestion of BRICS, Renal Score was performed, and this concluded the percentage of normal glomeruli, interstitial changes, and the renal function at the time of diagnosis. And this score was found to be predictive for end-stage renal disease. Importantly, patients with MPO-positive disease show more interstitial and more chronic lesions. So renal disease is a very important predictor for outcome and also for mortality. And there have been lots of worse renal prognostic factors described, as a lower GFR, the special histological features I just showed you, MPO disease, especially for the more chronic lesions patients exhibit, a poor GFR or recovery, persisting proteinuria, renal relapse, and also age and comorbidity. Now, how to perform the diagnosis? The diagnosis is done by combination of clinical features, the presence of ANCA, and importantly, the histological confirmation, which is still the standard for diagnosis. You have to exclude other situations like other autoimmune diseases, infection, drug-related induced vasculitis, malignancy, and sarcoidosis. And importantly, time plays an important role. But the diagnosis can be very, very challenging. This is really true in ANCA vasculitis. So initial symptoms are frequently misdiagnosed, as you have seen in the case I presented to you. They may be non-specific and may last for weeks or months and may mimic infection or malignancy. And on the other hand, they may happen also very, very sudden. The lab is not very specific unless ANCA testing has been done. And patients may be also asymptomatic for a very long time. This is true for renal disease and also for single lung nodules. Hematuria is a very early sign of active renal disease, but if your analysis is not done and interpreted in a long time, it's a real challenge, so the diagnosis is often delayed. Distinguishing between active disease from infection and damage may be very difficult, especially also in ENT disease, where you often cannot really say if changes are due to underlying activity or infection. And each patient, and this is very important, may present in a very, very different way. But interestingly, patients behave during their course of the disease also in a very similar way, the individual patient. So when suspect vasculitis, you may think of vasculitis if you have a patient with persistent systemic symptoms and special or specific features. You may also think in terms of a pulmonary renal syndrome if you have pulmonary features, and hematuria. You may think of a patient of systemic vasculitis if you have skin purpura and systemic features, such as constitutional symptoms, for example, and also in unexplained clinical situations like persistent sinusitis. But you may also think of it if you see a patient that has been seen by many specialists and has therefore many isolated diagnoses, which is always unlikely, so you have to join the dots. But if you suspect vasculitis, you should start immediate diagnostic workup, and this includes a baseline evaluation with the full medical history and physical examination, and a full set of labs including inflammatory parameter, chemistry, full blood count, importantly urinalysis, but a full workup of the immunological parameters and also infectious serology. Imaging should be done by a chest X-ray, but so much better by non-contrast thoracic CT scan, where you also can detect the nodules. And in addition, you should perform a sinus CT. Clinical assessment is very important and includes also ENT examination, which should be very carefully done. You should biopsy, if possible, any lesion which is easy for a biopsy. Now, what's the role of the renal biopsy? And I think biopsy is still the golden standard, even in times of ANCA and the presence of ANCA. It's especially important if you have typical features, but the patient is ANCA negative, or the other way around, if you have a positive ANCA titer, but no typical vasculitis features. You should also biopsy patients with impaired renal function, because the biopsy will give you prognostic information and will provide you information on the degree of chronicity and activity that the creatinine is presented by. You should also exclude other glomerular diseases and secondary vasculitis, especially in presence of high proteinuria. And you may also perform a biopsy a little bit later in the course if you have an inadequate treatment response or unexpected clinical cause. And of course, if you suspect a relapse. You may avoid it if you work in a very experienced center and have a patient with clearly high PO3 or MPO ANCA in presence of hematuria and normal renal function. So in this case, you may be very early in the course of the disease. Of course, you have some contraindications. But importantly, if you have see a patient on Friday afternoon, biopsy should not delay the initiation of treatment. So you may start with treatment if you highly suspect vasculitis, and the result of the biopsy will not too much be affected if you perform it 2 days later. Now, if you have the diagnosis, you may plan the treatment, but also here, you have to know exactly what you're going to treat for then. So intensity and duration of the treatment depends on the severity of the disease, of the organs involved, and also on prognostic factors like PO3 versus MPO disease in terms of relapse, for example. So localized or early systemic disease like skin disease or arthralgia or localized ENT disease requires less aggressive therapy than generalized or severe or refractory vasculitis. Treatment itself includes 2 phases. First of all, you will start with the remission induction phase to rapidly control disease. And if the patient is in remission, you will follow with a remission maintenance phase to prevent relapses and smoldering disease. Usually remission occurs after 3 to 6 months after induction therapy and is characterized by absence of any sign of active disease. So here again, the evaluation of the patient is very important. You have to know that the patient is in remission before you switch to maintenance therapy. And if you may detect active disease after a prolonged course, you may suspect a failure to treatment response or refractory disease. So this is a very important situation because it has a consequence for the patient. In addition, you have to evaluate during the whole course of the disease, all the comorbidities, and I will come to this later. So the prognosis with new therapies has very much improved, with remission rates of more than 80 to 90% and survival rates of 70 to 80% by 5 years. But in a study, which is some years ago from former EUVAS studies, importantly, infection is one of the most important causes of mortality in these patients. And in the former studies, we think that it was mainly driven by the high dosages of glucocorticoids. But infection is still one of the most important factors you have to take care of in the care of patients. In the late mortality after 1 year included cardiovascular disease, and this is also very important in the management of patients, since these patients have an increased cardiovascular disease, which is independent of the typical and usual cardiovascular risk factors. But you have to take care of malignancy, and again, infection was also a contributor after a year. Further important prognostic factors are older age, lower GFR, more severe disease and damage, of course, and also early relapse. Now, relapses are our everyday challenge, and they occur still in about 38% of patients at 5 years. They cause damage, morbidity, and renal relapse is a very important determinant of end-stage renal disease. It's characterized by recurrence of hematuria and or an increase of serum creatinine. So the monitoring for relapse is essential lifelong. Relapses may occur actually at any time, and you have to early recognize them. So you have to see the patient frequently. Symptoms often are the same or play the same sound of music as they did initially. So you have to sensitize the patient that he really has to look also for his own, for any symptoms similar that those he had already. And any other risk factors have also been described, as have been described ANCAs, of course. I mentioned initially that, or at the beginning of the presentation, the higher relapse rate with ANCAs, with PR3 ANCAs when compared to to MPO ANCA. And this has been documented by lots of studies, and here you see it shown it by the RAVE study, the higher risk for PR3 positive patients. With new therapies like rituximab, the relapse rate under therapy has improved remarkably, with relapse rates of 5 to 10% of the patients. But if you discontinue the therapy as shown here, patients again will relapse, and relapse rates start to increase after 8 to 10 to 12 months, mainly when B cells come back. So a B cell return before 12 months was predictive for relapse in a smaller study here. But on the other hand, remaining ANCA negative after treatment with rituximab was associated with a lower relapse risk in another study. So unfortunately, we don't have any factors that are predictive for relapse in ANCA vasculitis. But besides the fact that you have high risk with PR3 positive disease, ANCA follow-up may be helpful, and ANCA monitoring may be helpful to recognize settings that have been linked with a higher risk for relapse, such as persistently elevated ANCA levels after induction of therapy, or also in remission, a significant increase in ANCA levels, and a switch from negative to positive, but also ANCA positivity at the time of switch to maintenance therapy. But importantly, in these settings, you may carefully see your patients and ask even more carefully as you do it usually. But you don't have to start treatment or to change treatment, and initiation of treatment is not based on ANCA levels alone, although only on the basis of clinical features. In addition to ANCAs, also other risk factors have been described as clinical factors like the diagnosis of GPA, lung and upper respiratory tract involvement, a lower serum creatinine, and situation of a previous relapse, and importantly also chronic nasal carriage of Staph aureus. And there has been also other treatment-related factors such as early discontinuation of immunosuppression or less therapy, and mainly early cessation of therapy. So patient care will be lifelong in our patients with ANCA vasculitis, and a close follow-up is required initially, or if the patient has problems in terms of disease activity, but also even equally important in terms of infection or other comorbidities. In remission, I personally see my patients every 3 months, and you have to do a clinical visit with a lab, with inflammatory markers, including renal function urinalysis, of course, full blood count, and ANCA and immunoglobulins, especially in the treatment phases with rituximab or even afterwards. Clinical assessment focuses active disease. You have to check if the patient has an adequate treatment response or signs of active disease, or in remission if there's an early sign of a relapse. And in these situations, also a score system like the EUVAS may be helpful tool to realize is there any sign of activity. But importantly, you have to ask your patient for special symptoms. You also have to check treatment-related side effects and if there are any signs, especially of infection. And you should also know in the individual patient if there's a higher frequency or susceptibility of infections. And you also should be aware of the immunotherapy burden the individual patient had already. You should also know something about the prognosis your patient will have. This includes also damage that might be due to vasculitis itself, such as bronchiectasis, for example, and they are also very important for infections, so everything is linked with others. And also drug-related damage, of course. You should take care of comorbidities, blood pressure, lipids, diabetes, and body weight, and importantly, on quality of life. You should talk about with the patient every visit about this issue, and if wanted, or you may recommend also psychological support. And I think, especially at the beginning of the disease, it's important to give the patient a perspective of the disease. So they are thrown in a chronic setting with vasculitis, and they really need to know that they will have a good chance with high remission rates, and if managed adequately, they will come back to a real good, adequate life. But they have to make their own contributions, and some of them have, of course, to change their lifestyle. And periodic assessment importantly involves the management of cardiovascular disease, the detection of potential malignancy and osteoporosis, but also a plan for vaccination. So I come to my end, and I would like to know you that, as I've shown you, these are so many factors contributing in interdisciplinary management of patients, and all the components are connected and related to each other almost inseparably. And if you see the patient, you always have to keep in mind a short-term plan to focus on the recent programs, but you have also keep in mind a plan for the next 10, 20, 30 years. And this will help to improve quality of life and better understanding of the disease. So I thank you very much, and I'm open for any sorts of questions.
Well, thank you, Irmi, for a wonderful talk. And we now move on to the question and answer session. And there are a couple of questions. And the first one is whether you ever encountered a case where ANCA-associated vasculitis was highly suspected, but the patient turned out to have an infection. And do you know what kind of infections are particularly known to mimic the symptoms of ANCA-associated vasculitis?
Okay, thank you, Ingeborg. To be honest, usually it's the other way down. It's the opposite. So usually you have the opposite situation. You suspect infection, and then you will diagnose vasculitis.
Yeah.
But there are many situations where you may have, for example, a pulmonary renal syndrome. Mm-hmm. And this may have many, many reasons. If you have a patient with pneumonia and maybe he's on anticoagulation, so he may have hematuria also. And if you have a severe pneumonia, you may have a decreased renal function. So there are many sorts of pneumonia that may mimic infection, and you will have or may mimic the situation by itself. Importantly, also situations of endocarditis, especially infective endocarditis, will mislead you. So ANCAs may also be positive in endocarditis if you want. There may be some sort of false positive, but you may find ANCAs in these patients, and they may present with similar symptoms. In addition, they may also have purpura that might be due to therapy or to the endocarditis situation itself. So, and this is a very dangerous situation because treatment definitely will be the other way around, and you will kill maybe the patient with immunosuppressive therapy in this situation. So you have to really carefully evaluate these patients.
Yeah, these are the most challenging patients, I think, that we sometimes have to deal with. Making the situation perhaps a little bit more complicated even, there was another question from the audience which links to this, namely whether you can say anything about the positivity of the ANCA test. The question is whether with the initial presentation, perhaps with only a few mild symptoms, can the ANCA test be negative, and would it be worthwhile perhaps to repeat it later on to find out whether indeed there is ANCA positivity, and will it become positive when you wait for a certain amount of time and when you wait for the clinical picture to be more typical?
Yeah. Well, ANCA testing is important, that's true, but there will be some patients, especially initial of disease with more limited disease, such as ENT disease or very beginning of the disease, early disease, and they may be ANCA negative, and they will develop ANCA in the course of the disease. So if you have typical symptoms and ANCA negativity, it of course doesn't rule out ANCA vasculitis. And I think in this situation, especially the biopsy is very, very important to early diagnose the disease. And especially in ENT disease, biopsy may be very helpful. And I think frequent ANCA testing may reveal the ANCA positivity if the patient became more systemic within the course of the disease, of course.
Yeah, so you would advise to repeat the test, I think.
I would repeat the test, of course, later on, yeah.
Okay. And another question is, you are seeing lots of patients in the outpatient setting. Can you say a little bit more about what kind of alarm systems are there for a patient to be sent into the hospital?
Well, I know my patients, of course, so I know some patients will present in a very dramatic way, and there's nothing behind, but which is even more dangerous is the opposite. They won't tell you that they really bad. So if I get a phone call and I hear the patient that he's short of breath and says, oh, it's not that bad, so I tell them, you have to move to the hospital. And I think from the clinical point of view, there are some situations where it is really, really important. And these are if a patient develops hemoptysis and sudden dyspnea. So sudden events are always very important and have to be followed dramatically. So these patients have to be immediately admitted to the hospital, because especially this alveolar pulmonary hemorrhage may occur within just hours sometimes. So it's very important to that these patients are followed up in a clinical setting. Yes. But also if a patient has a very, very severe infection, and you have, this is why you have to be aware about the susceptibility of the individual infection spectrum. So also severe patients with severe infections, you have to admit to the hospital. And of course, I do admit patients for biopsy or for bronchoscopy, which is also very helpful in differential diagnosis.
Yeah, there is in fact another question about biopsies. You've discussed the merits of biopsies and of various biopsies of various organs. The question is, if a patient has skin manifestations and you take a skin biopsy and it gives you enough details to give a diagnosis of vasculitis, but the patient also has renal symptoms, do you think that a renal biopsy would then be necessary in that particular situation?
Well, it depends. So if you have a patient with ANCA positivity and cytoclastic vasculitis, and if you have a new onset of hematuria and still a normal renal function, you may be quite sure what it is. And if you're very, very early in the course, you may avoid it, but you really have to carefully watch what is going on. But if you have an impaired renal function, I really would go for a renal biopsy, of course. Yeah, and I think also you have, yes, that in this situation it's important that you have ANCA. But if you don't have ANCA, it's always very, very difficult. And I would also like to mention that it's very important to biopsy the most recent lesion, because if you don't biopsy the most recent lesion, you may not see immune complexes that may be present, and these might be a very important indicator for other etiologies like immune complex vasculitis.
Yeah, if you don't do that, then as a pathologist, we will probably see some aspecific reactive changes, and we will not make a diagnosis. I think from all of the things that you say, it's probably very important also to emphasize that the experience you have with these patients, how to diagnose them and how to treat them, is probably so important in order to make the correct decision, which is actually patient-tailored. The last question I have is about the relapses you discussed at the end of the talk. And the question is, in your opinion, how often and in what way should a patient be monitored in order to detect a possible relapse as early as possible?
Yes, I think, as I indicated, I see my patients at least every 3 months. I think that's fair. And if you have a patient with a higher risk of relapse, or if you have a patient that has an increase in titer and it's a PR3 positive patient, then I sometimes see them every 2 weeks, every 2 months, of course. Yes. If you have a young patient, the young patients may also be able, but also older ones, but if you have an adequate compliance, then you can try that the patient does at home his Uro 6 and if he does the urine sticks, he is going to call you. So I have some patients that do their urine sticks at home once a month, for example, and I see them every 3 months. So if they are pathological, or if the urine sticks shows any red cells, they are going to call me, and then we are going to make our further steps. So I think this is important. And also in the cold season, sometimes relapses may be triggered by infection. So this is, I think, very important. And if patients have many troubles with infection, I'm going to see them a little bit more frequently to early detect both of them, of course.
Well, I mentioned it was the last question, but in fact we have another question from somebody who is joining us from Argentina and who is thanking you for a wonderful talk. And the question is whether you have experience with patients who have both renal and gastrointestinal involvement. If you could say, if so, if you have that experience, something about the prognosis. And there's actually a second question after that, but perhaps you can first comment on the first part of the question.
Okay, so renal disease is seen very frequently in about 80% of our patients with systemic disease, while gastrointestinal disease is less common. It's more common actually in eosinophilic granulomatosis, but it definitely belongs to the severe findings in the patient. So it might be also a life-threatening complication. So in these cases, you have definitely to treat them like a very severe disease. But you may know that the treatment might not too much differ, because also renal disease you treat in a very aggressive way if you want, or with an amount of immunosuppression to get renal remission. So you may treat both at one time, of course. Yes, so I think that's mainly.
Okay, then there's another question for which I certainly don't have any experience, but the question is, what is the best way to assess facial pain in patients with limited disease and differentiate the damage from active inflammation in this scenario?
Oh yes, that's a good question. That's a difficult question actually, because I personally, I always do a combination. I have a cooperating ENT colleague who is going to see my patients, and it's very important to evaluate if the mucus of the ENT system is pale or if it looks inflamed. And you have also signs that indicate granulomas. So if you see some of granulomatous inflammation, it's mostly easy. But importantly, you may have chronic damage, and in chronic damage you may have scars, and especially in the ENT system you may have all those smoldering infections, and then it's really difficult to differentiate. What I think is very important to combine the clinical investigation with the sinus CT, because the ulcer destructions are important, especially in the follow-up. And if you see signs of active disease close to the bone, then you really have to intervenate, and then it's more in the direction of active disease. But as we know, a very low level of disease activity, of underlying disease activity, so to say, might be present also in patients that we would concern as they have remission.
The number of questions is at the moment sort of exploding. So we will do, I think, a few more. We still have some time. I have one technical question for the organizers, mainly that my window for the questions is really very small and I don't know how to enlarge it. But There was one practical question, whether this is recorded because somebody missed out on the first part. Yes, it is recorded. And that person is also thanking you for your very nice presentation. One question which pops up is whether you personally use titers of the ANCA test to look for disease activity.
Well, I combine it, yes, an elevated, I combine the ANCA data. I mean, I am aware this is a patient who is always high titers, and this is a patient who is always ANCA negative. So that gives me some information, but I won't treat the patient, of course, only based on ANCA titers. So this is, I think it's very important. You can include it in your spectrum of evaluation, of course, but it's like a puzzle, but it's informative, but you're not going to treat ANCA titer. You treat symptoms and signs of activity. So I usually wait if the patient develops something. And importantly, after infections, for example, or during infections, ANCA titers might rise and they come down by themselves after the treatment of the infection. So this is important information, and it's not specific enough that you may treat just ANCA titers.
No. But it's then of interest, of course, that they do also in that situation seem to be indicative of disease activity.
Yeah, that might be. Might be of underlying.
One very interesting but perhaps difficult question is, in your experience, is idiopathic pulmonary capillaritis, which is ANCA negative, more refractory than pulmonary manifestations in ANCA positive disease?
Yes, there's something in, I hope I got the question, but there are some observations that the interstitial usual pneumonia, this interstitial fibrosis may occur before patients develop ANCA, and these cases are really associated with a higher mortality. There are also studies, interestingly, that if you treat these patients, they have a better outcome than if you treat them not. So there's a nice study, it's a little bit older study, but they treated patients that were diagnosed as interstitial pneumonia and developed ANCAs, and these patients who were treated with cyclophosphamide in the study, they had a better prognosis than those who were not treated. So that may have a therapeutical implication. And it's a completely different setting, and it's really a subset of patients with MPO positive disease. And I think it's a different phenomenon as compared to the typical features of capillaritis, which is a more severe acute event. And acute lesions have always more chance to heal than scars have, of course.
Yeah. Okay, well, I now get a sign from the organizers that unfortunately we will not be able to answer all the questions. It's almost 3 o'clock and we have to finish the webinar. The webinar is recorded and you can find it back later on at the RITA website. It will also be posted on the EUVAS website. Perhaps we can, once it's posted on the website, also look into all the other questions. Thank you everyone for attending this and for being so active in asking us all these interesting questions. Irmi, thank you so much for a really wonderful talk. This will finish the webinar. Bye-bye.
Thank you very much.
Thank you.